Before I introduce the speakers, I just wanted to talk a little bit about, the importance of housing and the importance of street medicine, just to kind of set the table. Housing is health, period. And what I mean by that is that when we have roofs over our head, many things that most of us don't have to worry about is that we feel we're more likely to feel safer, have stability, get regular sleep, have access to sanitation, hopefully have a heater on cold nights, and then hopefully have air conditioning on days like today and have a place to store our items. I don't have to worry about losing my birth certificate when I'm trying to go to a doctor's appointment. But now imagine being unsheltered and not having many of those luxuries that we probably often take for granted. People experiencing homelessness deal with chronic stress, to say the least, have limited access to healthcare, are exposed to harsh and unsanitary environments, which all contribute to accelerated aging, what is now being called as inflammaging, and results in significantly higher health conditions and premature death. And we know that people experiencing homelessness have increased mental health issues like anxiety, depression, PTSD, and may find themselves turning to substance use to cope. I was extremely saddened to hear stories, even stories of females using stimulants to stay awake because of fears of assault in an encampment. And that's a reality to some people, unfortunately. And while healthcare is still a priority, it is incredibly harder to access traditional healthcare the way that we think of it in, our brick and mortar clinics. And so many people experiencing homelessness just suffer, and, continue to suffer and live with untreated illness or exacerbated illness until it's such an emergency that they go to an emergency room. And so street medicine, as you'll hear, is an emerging field of healthcare where care is being provided to people experiencing homelessness in their lived environment and respectfully on their terms. I appreciate the DA's use of the word dignity, and really it is using that dignified approach to deliver healthcare in their setting. And it allows that building of trust and provides the care that's needed. Street medicine is now recognized at the federal level. We have a billing code for providing medical care in the field. And across California, there's a growing number of providers. We are so lucky in San Diego to have these two and many other providers. In San Diego, we have a statewide collaborative. The state has put out guidance for our managed care plans to support street medicine providers. And conceptually, the way I think of street medicine is really as a harm reduction intervention, because while housing is the main solution to homelessness, as long as we have unhoused San Diegans, there will be a need for street medicine. And in fact, this is a growing need. Our 2024 point in time count results show that we have 6,110 unsheltered individuals experiencing homelessness, which is an 18% increase from last year's point in time count in terms of unsheltered individuals. Thankfully, we do have efforts like street medicine, and they build trust with clients, and they're not only providing healthcare, but as you'll hear, they're also providing other opportunities to connect people who, after gaining that trust, may be more likely to take up services or referrals to things like shelter or housing. And lastly, I want to say that our Board of Supervisors has unanimously approved a street medicine initiative to expand our coordination and capacity of street medicine efforts in San Diego County. This allows us to advocate for legislative change that's needed and regularly convene our partners, like the two we have here today, as well as our plans, our health plans, those with lived experience, and many other partners to work on these challenges. And with that, I want to introduce our wonderful two speakers, who I know and really, really respect a lot. Katie Wood is our Senior Director of Special Populations at Family Health Centers of San Diego. She has worked in the field of substance use treatment for the past 16 years, serving a variety of populations, including patients on medication-assisted treatment, individuals with co-occurring disorders, people experiencing homelessness, and people living with HIV or AIDS. Katie is passionate about educating and implementing harm reduction strategies within the substance use and special populations, strengthening the service delivery for underserved communities, and working to reduce the stigma and shame that impacts a person's experience accessing services. And secondly, Megan Partch, Dr. Partch, has worked in the field of mental health and substance use disorder treatment for nearly 20 years. She earned her She earned her bachelor's from SDSU, her master's in clinical mental health counseling from USD, and her PhD in counselor education and supervision at Oregon State University. Dr. Partch joined Father Joe's Village in 2015 as the behavioral health program manager, providing oversight of their mental health and substance use disorder treatment programs. And in 2018, she joined the Village Health Center, their on-site FQHC or Community Health Center, federally qualified health center, and Healthcare for the Homeless Clinic as the clinic director. And then additionally, she is a part-time faculty member at the San Diego City College in the Alcohol and Other Drug Studies department, where she teaches intro to substance use disorder counseling and co-occurring disorders. She serves on the Healthcare Advisory Board member for Happiness Advantage. And outside of work, she enjoys time with her daughters, Katie and Allie, spoiling her pets, baking, and spending time outdoors in the San Diego sun. So with that, I'll turn it over to Katie and Megan to take it from there. Thank you so much in advance.
Good morning. Thank you so much for having us today. We are very excited to share about a topic we are very passionate about. We're speaking with you today about street medicine, or as we would broadly call street health, because it is far more than just primary care and medicine that's being provided to our community members in need. So thank you, Dr. T, for the kind introductions. And we'll go ahead and kick it off from here. Our agenda with you in the time that we're spending together is to do some quick additional introductions, talk about some homelessness statistics, which Dr. T has touched upon as well. I'll give you a little visual for you visual learners like myself. We'll talk about what street medicine is at its core. We'll introduce you to our two separate health centers, Family Health Centers and Father Joe's Villages Health Center. We'll talk about some of the metrics, outcomes, and successes of our programs thus far. And we'll also be providing some information about continued learning and collaboration, should you like to join us in this endeavor. So we'll go ahead and pass it over to Katie for any additional things that you'd like to share in your intro, my friend.
Yes, thank you. Thank you so much, Megan and Dr. T. So as was mentioned, I've been with Family Health Centers for coming on 13 years. Most of my career has been focused on substance use disorder services, including providing direct care, but more recently, really focused on expanding services, looking at access to care and making sure that members of our community have access to SUD services when needed. About a year and a half ago is when I began to work and develop street medicine for Family Health Centers. It's been incredibly eye-opening to see the need in the community, particularly for those who do not make it into the brick and mortar sites for services. And as we get into some of the statistics in a bit, you'll see that there is a large number of people that are impacted and who could benefit from street medicine or street health. It's been an honor to collaborate and work alongside Megan. There's so many other service providers in the community that are very invested in serving this vulnerable and underserved members of our community. So happy to be here today. And Megan, I'll turn it back to you.
Awesome, thanks. Father Joe's Villages started our street health program in 2019. It is one of the many different programs and services that we provide to our community members in need who are experiencing homelessness or at risk of homelessness, and including those individuals who have experienced homelessness within the last year's time or so. We are outreaching to individuals in the streets, parks, and canyons, and it really was born out of a single individual who lived on the side of the health center building. And we saw her in various states of undress, never prepared for the elements. We saw her communicating with herself. She was very vulnerable. She had no belongings. She had nobody around her. There was really nothing to kind of tether her to the community or connect her to others. And there's the thought process for many folks, as Dr. T was referencing, kind of that brick and mortar style of care, the idea that, you know, she's just right around the corner. What stops her from walking around the corner and across the threshold into our health center? And yet there were so many things that stopped her from making it to us. And so our initial grant applications really centered around her as the story of the care that we felt that we could provide to our community members. And the rest is history. We've been able to amass a lot of resources and supports that have helped us to create this program, even when it was not a reimbursable service necessarily. And we're happy, I think, speaking on behalf of both myself and Katie, we're happy to share any tools and resources, not only through this presentation, but otherwise, if there's technical assistance that we can provide to you or your programs, please do join us. in some meetings that we'll tell you about in the future, and then also set up some side discussions with us. We're happy to be there as a resource to you. So looking very briefly at these point in time count results and also the medical examiner death rates. As Dr. T had referenced, unfortunately in San Diego, we see a growing number of individuals experiencing homelessness. And as individuals transition out of homelessness, there's a growing number of individuals falling into it. And there are a lot of specific elements that kind of feed into that. There's a number of variables, including systemic issues, including the low vacancy rates, the high cost of housing, a number of other things. But what we provide to you here is just, again, a very quick snapshot of us in San Diego, specifically the state of California as well, a high-risk area on the whole for experiencing homelessness, and a number of different populations of high risk as well, who are individuals who are experiencing homelessness, whether that be sheltered or unsheltered. So that information is here for you as well. That makes it especially pertinent for us to be able to bring care to individuals in our community. And this has been compounded with the experience of the number of individuals experiencing substance use disorder and the number of overdose deaths that we've seen increasing, as was referenced earlier. We're just now beginning to see that tide shift. And again, that's because of the collective efforts of individuals on the line and other community partners who are doing everything in their power to begin to kind of curb these trends. And yet any life lost to overdose is tragic. We're seeing, especially in the individuals experiencing homelessness, a disproportionate number of overdoses related to substance use, and especially fentanyl, which we know is cut in a number of other substances that our community members are utilizing, whether it be, as Dylan had referenced, individuals who fentanyl is their drug of choice. It is something that they are seeking out and pursuing for use. Or in many circumstances, we're learning that individuals were not expecting that was within the substance that they believed that they were using. Katie, I don't know if you wanted to share anything else on this slide as well before we move forward.
No, I think you covered it.
Great. So we'll be talking a bit about what street medicine is, definition, rationale, goals, and also some assessments.
So at the core is what has been mentioned. Street medicine is really going to the people. So it's providing health, social services directly in the environment where somebody is living. And oftentimes these can be places that are not intended for human habitation. It's taking primary care onto the streets. It's looking at diagnosing, assessing, treating. This includes or can include wound care, medications for addiction treatment, care coordination, a whole host of things that we'll get into in a bit. Street medicine is really founded in a harm reduction and low barrier approach. As has been referenced and we'll continue to touch upon, there are reasons that people don't walk into a brick and mortar. And so these individuals still continue to have basic primary care needs regardless of where they sleep. So it's really important that we remain trauma informed. We focus on really building relationships and building a rapport with individuals, because we need to understand what are the reasons that have been barriers to them accessing care. Street medicine really reinforces the idea that we need to break down stigma, shame, and judgment when we're working with people experiencing unsheltered homelessness. It's the same way that many of us for years have worked to reduce stigma for people experiencing a substance use disorder or a mental health condition. The language that we use, the way that we talk about people, it really matters. Keeping the person at the forefront really humanizes the experience. Homelessness is extremely complex. It takes many resources, service lines, many touch points to help address, and we need to remember that at the center of this issue is the person. And street medicine really supports the idea of exiting somebody from homelessness in partnership with housing services. So as we get into talking about what is included in street health or street medicine, street navigation, what are we providing to these individuals? The goal for a lot of people is to get into some sort of stable housing, and street medicine is often the entry point to help somebody get into that and pursue and be stable to get into housing. So some people ask why street medicine? Well, street medicine, there's many reasons why we want to use this model. One, it really reduces hospital admissions. It's a durable pathway into housing. It offers supports. It also offers screenings, and it really is designated to meet the people that to meet the needs of the people that are on the street. Um, we'll talk about some of the statistics, but oftentimes people have had chronic medical conditions that have been untreated for years. They might have a substance use disorder that's untreated. And this is really a way for us to go into the community and provide the care that people are not seeking through the traditional brick and mortar. There's a lot of wound care that's provided. We're able to do kind of think of what you access when you go into the doctor. We're able to do that through the street, whether that's blood draw, specimen collection, different offerings through the screening and assessment process. We send out teams that are really robust with different types of skill sets, different types of staff to really address and really use that holistic approach to address the complexities of what people are presenting. I think it is important to note that there is a difference in biological age of somebody experiencing homelessness versus people who are housed. And that difference is approximately 20 years. So if a chronological age of a person is, say, 50, their functional age could be closer to 70. And that's attributed in part to poor access to healthcare, nutrition, hydration, the exposure to the elements. As Dr. T mentioned, we're in a heat wave. The people being out in this 100+ degree weather day in, day out takes a toll on the body. We're also working with people who oftentimes have untreated substance use conditions or are combating some sort of mental illness. So there are a lot of reasons why going out and offering these services to people helps the collective community. Anything you want to add, Megan?
Yeah, so I'll springboard off of that. When we first started our program, our specific goals were really, as you'd referenced, Katie, to break down barriers that individuals experience gaining access to care, to provide just the same quality of care that you could receive within a brick and mortar in the community, which is a challenge in and of itself, given resources and heat and all of these other things, but finding creative means to be able to do so. We wanted to reduce the number of individuals experiencing homelessness who were using emergency departments and hospital stays to meet basic needs and to be able to gain entry to care systems that they didn't need. So we wanted to reduce those folks who were accessing higher levels of care more frequently than needed. To reduce early mortality, as you had referenced, and I know Dr. T had referenced as well, which is an unfortunate reality for our community members in need. To improve access to resources, as was referenced, and then also to foster this ongoing engagement. And one of the things that we were looking at as well is how many points of engagement would it take to maybe be able to get people into a brick and mortar? How much stabilization might need to happen, or what sorts of tools of engagement would happen to even get somebody to consent to care services? So a lot of different things that we were exploring anecdotally, things that maybe are not collected in the EHR. So we'll talk about that more in the future as well. But we had some pretty lofty goals when we were going out and saying, how can we begin to provide the most quality care possible outside of our typical brick and mortar environment? Katie, I'll hand it to you to chat a little bit about the housed beds assessment.
Yeah, so housed beds is an acronym, and this really was born out of the USC street medicine team, who have been the leaders for many of us here in San Diego, as they have a very developed street med program, and they developed this assessment, really recognizing that the unsheltered homeless population requires a specific set of questions to better understand the reality. And how do we develop a treatment plan that will fit into the context of the lives of somebody experiencing unsheltered homelessness? So, right, when you think of a provider who's prescribing medication to somebody who's housed, they likely may not factor in whether the person has access to a restroom, or how they're obtaining water, or do they have, what do their meals look like? Are they eating? What's the access to food? And what we've learned is, our definition of a meal may be very different between somebody who's housed versus unhoused. And so this tool was developed to really evaluate and look at really reaching a higher level of understanding to what are the population specific questions that we need to ask. So the house beds goes through looking at not just is somebody currently homeless, but how long have they been homeless? Where are they living? How many outreach and engagement attempts does somebody need? Do they have existing support? Through some of the research of USC, we've seen that people, they think they've had engagement with service teams, but really the outreach was from their tent mate or a neighbor in their encampment. And so just the ideas of what is outreach and how do we really tailor engagement to that individual. The tool is really designed to ask questions by all members of the health team. It's not intended to be used in one setting. It's over time. We want to track what are some of the changes for the patients who are currently unsheltered? We want to look at what is their utilization in healthcare been. To Megan's point, have they been service connected in the past? Have they not? How long has it been since they've had a primary care appointment? Are they justice involved? For those of us that work with the justice involved community, it's very important. If people are not checking in, if they were recently released from incarceration, if they have a probation appointment, we want to know so we can support somebody. And we've done advocacy where we've called probation officers and said, we're sitting with one of your probation, patients, and they don't have a phone. They can't call you. They don't know where to go. They don't know what day and time the appointment is, right? If you're not housed and, working, kind of like most of us probably are, we're very aware of what day and time it is. But somebody who's unsheltered may not know what day of the week it is. They might not know what time of day their appointment is. They might lose track of time more quickly than somebody who's housed and has more of a schedule. Um, and so we want to look at, it's really important for our providers when they're looking at what medications are they prescribing. Again, if somebody needs to take medications with food, or if it's a medication that could cause some GI upset, what's their access to a restroom? We know that oftentimes people don't have access to sanitary conditions, and this can really impact maybe their desire to take a medication or their ability to take it. And so this tool, for us at Family Health Centers, we have this embedded in our electronic health record. Our medical providers complete the portions that they're aware of on any given visit. And we opted to put this at the forefront of our EHR so that other providers could see the assessment. So other providers could ask questions. We want to use this also as a teaching tool to our system of care to really evaluate and understand what it takes when working with somebody who's experiencing homelessness. And it also benefits those patients that are unsheltered homeless who may be coming into a clinic for a visit. This just provides greater context to the care team, and it can be done by anybody, like I mentioned. So we have on our team, it can be a case manager assessing or asking questions, a provider, the substance use disorder counselor, the mental health clinician. So it's really anybody and everybody. It's all hands on deck to make sure that we fully understand the person that we're working with and treating.
Agreed. I think what I love so much about this is that it gives us greater insight into the uniqueness of each patient, and it really is a strengths-based approach. Our team is utilizing this assessment particularly to learn about what's strong versus what's wrong. I know a lot of our community members, are marginalized and stigmatized and really pushed to the edges. And so this allows us to really look at what resources do they have at their disposal, either in their personal or in their support network. Maybe it's their pet that's the most important thing to them. And so this allows us to collect that great information that helps us to really tailor care, but also outreach and engagement to these individuals. We do not do a one-size-fits-all approach for any patients, but especially not for those individuals who are being served in the community. Even in the tools of engagement that we utilize, water bottles might be necessary for somebody, or protein shakes might be necessary for somebody based upon the medications that they're taking, as Katie was referencing. Hygiene kits may or may not be necessary for everybody. So we're always kind of looking at, what do you have access to? What are your needs? What are the things that you have at your disposal readily? And what strengths do you come with? And what can we kind of empower you to do for yourself? And for those things that you cannot, how can we teach you? How can we support you in that journey so that you can get to a point of greater autonomy?
And Megan, just one more point quickly before we move past that slide. The daily schedule, oftentimes we'll hear, patients were scheduled an appointment in a clinic during business hours, typically, right, Monday through Friday, 8 to 5, and they didn't make the appointment. And so they're almost further penalized because they didn't make that appointment. They may get discharged from care, discharged from a service line, discharged from an organization. But really, when we take a step back and we look at somebody who's experiencing unsheltered homelessness and what it takes to leave the encampment or their space for the day or for an appointment, that could mean leaving behind all of their property. Right. And that includes, it could include important documents. And we often, are helping people get a birth certificate, get a second ID, get a third social security card, whatever that is. And so it's really important as a service provider to step back and think, this isn't just as easy as somebody hopping in their car and driving to their medical appointment and returning to their home. People are often faced with this decision of, Do I follow up with my primary care appointment? Do I follow up with my substance use disorder counselor? What is the risk of doing that? And it could be at the risk of losing all of their property, all of their possessions. And so it's really, we need to recognize that it's striking a balance between what can a person do, and it may not be an assumption of they just don't want it bad enough, right? They don't prioritize their health. They don't want to make it to an appointment. It oftentimes is not that. And so just to underscore why street medicine is so important is the person can keep that autonomy. They can keep all of their possessions. They can keep an eye on it, and they can have the service provided to them. So just want to highlight why that daily routine and collecting that information about activity during the day is really important.
Agreed. Thank you. Let's hear about family health centers.
All right, so Family Health Centers, we are one of the nation's 10 largest FQHCs. We operate 90 sites across San Diego County, including a myriad of primary care clinics, our behavioral health centers, dental, vision, et cetera. We last year provided care to over 227,000 patients. The statistics are on the screen, but approximately 91% of them are low income, 29% are uninsured. And we offer a range of these health services throughout the region. Many of these are taken out through street medicine. Dental and vision are not, but we'll get into more specifics about what Family Health Centers is doing. But street medicine, we launched just about a year ago. We're approaching our 1-year mark next month. And we are targeting street medicine near a primary care clinic. The idea for us is that we want to treat people in their lived environment, but we also want them to know what resources are available in the community for if and when they're ready to take that next step, whether that's walking through the doors of a primary care clinic, whether that's through to a vision clinic or for a behavioral health, mental health, or substance use disorder program. So we're strategically launching our street medicine to be within regions of where our primary care clinics are.
And we have your multidisciplinary team up here too, Katie.
Oh, thank you. So our team, typically includes right now we have a medical provider and a PA. We also have an RN and an LVN who go out with our team. And then on any given day, we have, whether it's peer support, case managers, different levels of clinicians, test counselors, outreach workers, along and paired with our medical providers so that we can make sure that we're providing that comprehensive care. Our care currently includes full scope primary care. We also do mental health screenings. We do have a mental counseling center that's mobile that is co-located with our teams at different intervals during the month. We do HIV and hepatitis C testing and linkage to care along with PrEP. We have a host of harm reduction services that we are offering. We also deploy a substance use disorder counselor who's doing an expert model, so doing screening, brief intervention, and referral to treatment. They are also able to support the patient at their tent. We don't require that the SUD services be received in a clinic. And we also, and I know Father Joe's does a lot of this too, we're doing MAT inductions and then kind of full scope case management.
Wonderful. All right. So to switch gears briefly and tell you a little bit about Father Joe's Villages as an organization, we have 4 pillars: meeting basic needs, making health a priority, which is the health center, investing in children through our therapeutic childcare and family shelters, and also strengthening self-sufficiency. And we do each of these through a number of different services and supports and programs that are meant to be low barrier and engage our community members experiencing homelessness through a one-stop shop model. And so Father Joe's Villages is constantly reinventing and creating new programs and services as needs in our community change. And this is just a number of the different services and supports that you can find not only on our campus, located in East Village in the downtown San Diego area, but also we're kind of a hub and spoke model. This is our hub. We have a number of different housing locations throughout San Diego County that we could consider our spokes, as well as our street health program that deploys out into the community and moves about where we're needed. So while Katie was sharing about the vast size of family health centers, I just had to kind of smile, because I think we are probably the smallest federally qualified health center in the nation. And we served about 4,000 unique individuals last year. So we've got family health centers, which is a very large system. And then we have Father Joe's Villages Health Center, which is this kind of petite little space. But that allows us to be really agile to kind of invent new services and supports as they're needed by our community members, which I love. So we provide primarily outpatient services here through a combination of scheduled and also walk-in services daily, including the ones that you see here on the screen: primary care, psychiatry, dental, behavioral health. We have that walk-in access as reference. We do have an on-site lab because we recognize the many barriers to care that our community members face. And as Katie was referencing, the high risk for them coming to us of losing belongings, leaving their pet or their children with individuals that maybe they don't feel safe with, and so forth. We do referrals to specialty care as needed, and we have a high emphasis on insurance enrollment for our community members as well. And those individuals who do insurance enrollment this year have begun to deploy with our street health team too, as that's so necessary, given the growing population of folks in California who qualify for health benefits. Father Joe's Villages, as I'd mentioned, always has innovative services and programs being created and on the horizon. A number of programs that we've created over the last 5 to 7 years include medication-assisted treatment, our on-site recuperative care program that's in partnership with our shelter, case management, and also health center team. We have harm reduction vending machines, thanks to our partners at the San Diego Harm Reduction Coalition, who was kindly funded by the county. For one of our harm reduction machines that's on our campus, and then also one through a partnership with Neighborhood Healthcare through some generous funds from SAMHSA. So we're very lucky to have two 24/7 access vending machines on our campus, one that is completely stocked with 180 boxes of Narcan, and another that includes fentanyl and xylazine testing strips, wound care supplies, and sharps boxes. And so you can see we've got QR codes and information here. I'm happy to share this flyer with you if you're in the area or support folks in the area. And this includes the community at large. One of my favorite interactions with a gentleman who works at a 7-Eleven in the area. And I happened upon him at the front, and we were engaging in a quick discussion next to the Narcan vending machine. And he'd shared that he was tired of feeling helpless and hopeless as he was seeing individuals who are in health distress around his workplace. And so he was getting several boxes of Narcan for himself and his team members. And he said, I'm just so relieved to know that if something happens, I can do something while we're waiting for emergency services, and I can come back and I can get more of these boxes anytime I need. And so we certainly want to make sure that folks in the community are aware of these. Our community members in need are utilizing these frequently. And we most recently heard from Tara at the Harm Reduction Coalition that ours is one of the most frequently utilized machines in San Diego County, which I would not doubt. Many of you may have heard that Father Joe's Villages will be opening a detox program and also substance-free shelter in the new year. We're very excited about that. And Street Health is another one of those innovative programs where we said, let's pilot it. Let's see what happens. Let's see, we're willing to take a chance. And if it doesn't work, if it's not the right thing to do, then we can always kind of backtrack from that. But let's go out there and let's see how we can engage with our community members through these much needed services. So when we started small. You can see these McKesson bags here. If you work in healthcare, you've seen these supplies come in them. And for those who don't work in healthcare, think about when you go to IKEA and you get one of those big bags and you load it up as much as you can. That's pretty much what our team was doing. They were using as many bags and boxes and bins, and they were literally going out into the community with these bins and bags to provide support to community members in need. We went out on foot. We had a little bit later when we got some grant funding, we said, okay, let's throw on some, tactical backpacks that have all of these little great places to hide all the little materials that you need to have accessible and organized and at your disposal. And you can see some really amazing photos here of outreaching to individuals in downtown and also in Balboa Park encampments, some of our clinicians here. Much of the marketing for our program began through word of mouth. Kind of those mayors or designated leaders within encampments were the ones who sometimes were kind of engaging our team and feeling us out, and then able to go to other community members within that space and saying, trust them, they're here for you. And really liaising the relationships to say, hey, I want you guys to come and see Bob. He's got this wound on his leg. It's really not looking like it's getting better. In fact, it's getting worse. Can I connect you? And so those trusted individuals who were able to provide word of mouth marketing was what helped us to gain a foothold, as well as the branding, which really kind of let people know who we were, why we were there, and that we were possibly a trusted entity for them. What we have today is a growing number of vehicles, a larger team, a number of outreach workers. We've added a lot more services to our scope, and pharmacy, PDRX is a pharmacy partner. We're able to deploy some medications directly from our vehicles to community members. No controlled substances, but some of the more commonly needed ones like antibiotics, care for lice, and other sorts of things. We've got cell phones, we've got laptops, we've got printers, we've got MiFis, we've got all of these things. And if you ever need to know about how to acquire a vehicle, aftermarket storage, and all the crud that you can shove in it to provide street health services, I'm your gal. Let me know and I will get you a shopping list accordingly. And we're continuously growing our partnerships, acknowledging that if we can't be most expert and provide the much needed service that somebody is needing for them to be able to move towards stabilization, towards income, towards housing, whatever that might look like, then we want to connect them readily with that other team that can. So what it looks like for us today, we do have outreach and in-reach models, meaning sometimes we're going out and we're kind of cold calling, so to speak. We are engaging with individuals at their space of residence and offering services and supports. We do this through, the team that deploys into the community. We also have an in-reach model where some community partners will refer specific individuals and specific locations and provide some identifying information about them so that we can attempt to find them in their frequent environment of living. We also have a multidisciplinary team in partnership with PATH, and they provide the intensive case management, and we provide the care management to those individuals. As you can see in the box here about team members, we try and keep the numbers small so that we are not, overstaying our welcome and we aren't making community members uncomfortable. That means that absolutely anybody and everybody, as Katie was referencing with the house bed model, if that individual feels most connected to our nurse practitioner or to our MD, that person might be collecting registration information. They might be the person who's collecting vitals. It's really not a hierarchical approach as we sometimes see in healthcare. This is boots on the ground, everyone's in it together, and whomever that patient or the patient's trust or connect with is really going to be probably the person who's taking lead on that interaction. And you can see that we have hybrid roles as well. We have outreach workers who are very talented, who have skill sets with medication assisting. They have RADTs. So for those who don't know, that's folks who are beginning alcohol and other drug counselors, folks who are also skilled in case management. And so we're really trying to bring these hybrid modalities together so that our patients are best supported through a very small number of individuals in their home, so to speak. We are providing primary care, consistent psychiatry in the community as well, mental health counseling. For this group, I'm sure you're excited to know that we do alcohol and other drug counseling, naloxone, harm reduction outreach, a lot of education, a lot of deployment of harm reduction supplies through that. Medication assisted treatment services, as Katie had referenced, including induction and continued maintenance, connection to a number of different community resources and referrals, and then providing sustenance supplies. We're out in the community 40 hours a week, Monday through Friday. We also participate in a number of different care events. And so sometimes we are a bit more stationary, sometimes we're out deploying. Through the 3 vehicles that we have and the multiple care teams, we're able to hopefully strike a balance to meet both needs at any given time. So we'll talk a bit about some of our program metrics, our goals, and our objectives.
All right, so I won't spend too much time on this. I know our time is winding down, but in the past 8 months that Family Health Centers has had our team out in the field, we have served over 406 unique patients, and that has come to over 1,100 medical visits. You can see the number of HIV tests, HCV tests. I will note that our street medicine team, as Megan touched on grant funding, we applied for a SAMHSA grant for the benefit of homeless individuals, and that is the support team that we have that pairs with our street medicine team. So that is how we fund our support staff. Those are the staff that are helping to distribute the harm reduction supplies, whether that's the naloxone test kits, fentanyl, xylazine, and out there doing a lot of the engagement and helping to link people to whether it's ongoing case management, housing navigation services, et cetera. And then we also have, like I mentioned, our HIV and hepatitis C testing teams out in the community. And so we're able to link people who do test positive or reactive, and we're able to get folks linked to care. We were curious about where our patients were before their street medicine visit with family health centers. So, just a little bit of information. We found out that in the 12 months prior to the first street medicine encounter with our medical team, 63% of those patients had actually had some sort of visit with family health centers in that previous 12 months. 61% of those were medical services, and the remaining were support services. And on the next slide, we'll see just the breakdown of what those were. And I was surprised by this data, and we're still really looking into it to see what does this mean. But you can see that patients were connected for primary care services, behavioral health, and substance use disorder counseling. So we know that on some level, folks were service connected, but there's still a large number of people that are in the community who were not. And I will just preface this with this information is only for family health centers. So we don't know of those patients how many may have had an encounter with Father Joe's or other service providers in the community or an ED visit, et cetera. So this is very specific to our closed system. But it just shows that, we still have a lot of work to do, right? There are still a large number of individuals who were not connected as far as our data shows. The xylazine and fentanyl test strips, I have a little bit of data to share with you based on, we distribute test strips, and when a patient returns, we ask them a couple of questions. We ask them, one, did you use your test strip? And two, if you did, was it positive for the substance that you were testing it for? So in this case, either fentanyl or xylazine. The number of responses changes each week just because it's driven largely in part on self-report and the number of patients coming to receive tests and the number of supply that we have to distribute. So the next slide shows the fentanyl positivity rate over the last couple of months. Again, this is self-report of what people in the community are telling us their substance is testing positive for. So we're currently seeing a bit of a downtrend of people reporting positivity rates for fentanyl. Part of this could be that less people disclosed whether their substance was positive, or we may have distributed less test strips that week. But this is a good indicator for us just to have a pulse of what's going on in the community. The next slide shows you the xylazine self-reported. So this is the xylazine. So we're also seeing a downtrend. So just anecdotal information, but it is really helpful that our patients are coming back and providing us with some of the data and what they're seeing in their supply.
I love that you all are doing that. Thank you so much, Katie. So some of the things that we look at similar to family health centers are the number of patients who are seen, the number of visits that are provided, and the kinds of services provided. We do have our own definition of case management to look at care continuity and also individuals who continue to work with our team towards additional forms of stabilization, be that, again, income, housing, and other resources that are needed. We do look at the number of referrals that are placed to other community-based entities and other needed resources. We do track the number of individuals who are engaged in a street health modality that transition into brick and mortar. Historically, that's gone about 15 to 20% of individuals who are engaged first in the community will transition into the brick and mortar health center. We also look at the times and locations that are visited, the frequency with which we're serving people and the amount of individuals in those spaces. And that helps us as so many community members are now being moved and moving over time to time. And then we're also looking at total engagement. So in terms of some of the other elements that we want to track, we're looking here again at whether individuals are outreached or inreached. So the way that they're coming to know our team, we're looking at the different zones. You can see some of the different areas, and we're kind of tabulating through Microsoft Forms at the end of every single AM or PM shift. The team does a quick debrief on their ride back, and they go through a Microsoft Form together, and they enter a number of different variables that we're unable to collect right now in the EHR. But these are also variables that are not only helpful for us in terms of trending, as Katie was referencing with positivity rates for test strips and a number of other things, but this is also the sort of thing that helps us to articulate to funders that we are engaging even if a care service is not being rendered. And I think it speaks to the importance of this continued outreach and engagement, regardless of whether it's a billable point of contact, which we know healthcare, unfortunately, is a game of quantity, and you're reimbursed and you're paid based upon the number of billable services that are rendered. And yet so much of our street health program is not attached to a billable service, especially at those points of outreach and engagement at the onset of a relationship. And so it's really important for us to be able to collect great data about what our community members' needs are, where they're located, and the way that we're engaging and outreaching them to share the full picture of what's being provided in our community. Finally, this is very small, so my apologies, but we also do track the kinds of materials that we're giving out to people. And again, that's not a one size fits all. That's really based upon access and availability of other resources that that individual has or other supports that they have, and being very, very mindful about the things that they may need. We also provide our street health team with a $500 allowance every month. I know, very big money there. And we let them choose tools of engagement that are fitting for this season. And so we find that during the winter months, binder clips and tarps are very, important to our community members. I would not have expected that, but those are tools of engagement for our team. Times of year like this, it's a lot of ball caps. It's rechargeable fans that individuals can use. It's water bottles, all sorts of other sorts of things. And so really it's kind of seasonal, and it also depends upon other outreach and engagement efforts that other entities have had, where we don't want to duplicate things that folks already have access to. We really want to supplement the things that they don't have access to otherwise. So you can see that we do a lot of supplemental tracking via Microsoft Forms. So I don't know, Marla, if we'll have time for a success story. It looks like we don't. What I want to highlight here is this is Julie. We'll provide you a link in the chat so that you can hear her story firsthand. But she's an individual who was outreached to and engaged on a multitude of occasions and was not ready to participate in care. And as Dr. T had referenced, sadly, her story included the use of substances because she did not feel safe in her living environment over by Seaport Village. And now she has an animal, she's sheltered, she has a new beautiful smile, she has glasses, she has her medications that have been refilled for her, and she's stabilized and she's sober. So it's a really beautiful story. It's about 3 minutes. And again, I'll put that in the chat for you so that you can hear it from Julie first. If you're interested in continued learning, there's a lot of resources. Katie had referenced USC. They have a symposium coming up. If you need links to that, we're happy to share it with you. We also have a number of community meetings and other resources. Again, if you outreach to Katie or myself, we're happy to share that information with you, including anything that you saw in this presentation or additional questions that you may have.
So my name is Erik Berg. I'm the Interim Medical Director for Epidemiology and Immunization Services Branch at the County of San Diego. And happy to discuss with you all the county's program called OSAR, or Overdose Surveillance and Response. So OSAR is a relatively new program. It's multi-departmental and jointly led by public health and behavioral health, with a focus on overdose surveillance, investigation, response, and community engagement. Our our mission is to provide a comprehensive surveillance program, including identifying critical drug-related clusters to allow for a timely response to overdose events in the community and the monitoring of those outcomes. So we have a broad array of stakeholders that have contributed to our guidance document that I'll go into a little bit, and that are really partners in identifying trends in the community that warrant a response, and providing us data to be able to come up with that comprehensive picture of overdoses in the county of San Diego. So really the vision of OSAR, there are 4 pillars here. First is surveillance. I won't go into all of these boxes under each pillar. We'll touch on some of them later, but the surveillance piece, again, really trying to fuse a lot of different data sources to to be able to provide that comprehensive picture. And then through those data sources, through our surveillance systems, if we do identify a critical drug-related anomaly, we call it, we will investigate that rapidly. So investigations will take the form of medical record review, cross-checking different data sources, interviews with key stakeholders, and then really an investigation that confirms a drug-related anomaly that warrants a response. We'll get together our teams here at the county, public health and behavioral health, review the data quickly, and really this all takes place within 24 hours is the goal. And then a decision on that response. So how are we going to deploy a field response? That responses will typically include targeted distribution of naloxone, a distribution of info on treatment and services in the community, provider alerts, public messaging. And then really, community engagement and partnership. We can't do this alone. There's, again, many different fragmented data sources out there that we rely on partners to bring to us. And then really part of our job is to, when we collate those data sources and come up with trends that are happening, to be able to communicate that out to folks, to providers, to the public, to keep everybody up to date with accurate information. So some of our progress to date, we are, again, relatively new. We started last summer, so the summer of 2023. Since then, we've hired staff. We've refined our drug-related outbreak guidance. We're developing many different surveillance data products. So internally, we have a daily and weekly surveillance report that's automated based on emergency department surveillance data, EMS data, and really through those automated reports, if there is an anomaly detected, whether it's an increased number of cases countywide or a geographic cluster somewhere in the county, those surveillance reports generate an alert for our investigators. We've also developed a monthly report with the goal of having it be actionable data. Right now, we'll talk a little bit more about that. It's now an internal report, but really the plan for that, once it's refined, is to make that publicly available so that others in the community in this space are able to respond. We've also developed and are publishing publicly quarterly and annual reports to document medium and long-term trends in overdoses. And we'll again touch on that. And I want to say that, so far we've been emphasizing opioids, and really opioids are the biggest threat in our community in terms of mortality. But we are not exclusively focused on opioids, and that's part of the reason why the name of our program is Overdose Surveillance and Response, not opioid surveillance. So really, through our collection of different data sources and our team's facility in looking into those data sources, we've accommodated ad hoc requests and will continue to do so. Some of those examples are cannabis-related ED visits here in San Diego County, wound-related ED visits, looking into different ways to understand how widespread xylazine is in our community. And then we've also developed criteria for deploying responses. So that response piece, again, is huge. We want to have accurate surveillance information, but we also want to respond to those critical events in the community. So just to give you a little bit more insight in kind of our process, we do have this guidance document. It is very detailed. There's 19 pages. There's multiple flowcharts, but I want to kind of simplify it for the sake of our talk today. Essentially, again, we have these alerts that are generated from data, or we get stakeholder reports. We're in contact with EMS agencies, fire departments, law enforcement agencies, providers, and they come to us and say, "Hey, I'm seeing this worrisome trend. Can you guys look into it?" And so, these multiple different avenues for how information flows to us, which may generate an alert that will trigger an investigation, again through cross-checking data sources, investigations of medical records and interviews, and then really rapidly huddle internally at the county with leadership from public health and behavioral health to decide, do we need to deploy a field response? Again, this is a kind of a graphic representation of some of the different data sources, some of the different key partners where we're getting information in order to really validate and then to decide on a response. So just to give you a little, I won't go into all the details here, but this is an example of one of the automated alerts that we've coded into this data system. So one of our main sources of information out there is through our emergency department syndromic surveillance system. So really, this is active within 17 local hospitals here in the county, and we will, if there's an increase in overdose cases, then this system alerts us very rapidly about an increase in cases, which will then again trigger an investigation. So we look at this system daily and also weekly. And the syndromic surveillance is just one data system that we're looking at. We have similar criteria that we look at for EMS base hospital records, EMS pre-hospital care records, and OD map. And then again, if any of those data systems trigger an alert, that will lead to an investigation. These are just some of the numbers here recently in the last few months of alerts that were generated and subsequent cases, individual cases that were assigned to our investigators. And so these are a number of cases assigned weekly. So we're doing lots of investigations every single week, and those investigations will again sometimes trigger responses, sometimes not, but we're doing a lot of work on the investigation piece through OSAR. Then I do want to touch on one of the surveillance products that we are using. We've developed and are using internally for now. These monthly reports are, again, the purpose of them is to really produce actionable data. And we are looking at overdose cases that happen in sub-regional areas in the county. So if there's an increase in overdose in a particular sub-regional area, we're able to kind of track that monthly. And the goal of that, again, is to make this report public, to make it actionable, so community partners can know, hey, in this particular subregion in the county, we're seeing an increase in cases, and to be able to make informed decisions on deploying resources to that particular area. Also, we are, as mentioned, producing quarterly reports. These are publicly available on our website. And each of these reports are, they have a theme. So we provide data, but we also talk about kind of current themes in overdoses that we're seeing. Our most recent report was on xylazine and xylazine adulterated drugs. So I'm proud of these reports. I think they provide a lot of information and I hope are helpful for our partners in the community. Then we've also been putting in a lot of work on our overdose dashboard. So this will be a comprehensive source for overdose data in San Diego County, will be publicly available. And we are working through a lot of different data sources. This is going to be, and this will be public this calendar year. It's going to be an iterative process. So as we're able to develop each of these pieces, we'll continue to add to this puzzle over time. But again, we're looking through emergency department data, hospitalization data, syndromic surveillance, mortality information, poison control, EMS, and our local naloxone distribution program data. So really excited about this. It's been a lot of work to develop, still in progress, but again, this will be available soon, and we'll continue to refine going forward. And just the last couple of slides, I want to talk about a little bit more about the work that we've done. So through our surveillance systems, and this is back when we first started in July of 2023. So these anomalies that we're detecting really are going to be either geographic clusters. So was there a cluster of cases in a geographic area that may be concerning for an adulterated drug supply, a novel substance that's making people sick, or is it a spike? And a spike is going to be kind of an increase in cases jurisdiction-wide, so really across the county. So those are the different anomalies that we're looking for. We've picked up, an average of 2 to 3 per month since July of 2023. Each one of these are investigated, and then again the joint decision between public health and behavioral health on and if these incidents warrant a response, if they're validated and then warrant a response. And then this graph is just showing how we're obtaining information on these anomalies. So really the point of this is to show folks that we're discovering these anomalies through a variety of sources. It's not just these automated alerts from our data. It's really relying on you all in the community, on our trusted partners, and so. And we do, that's one of the points. The second point is that, we do see fluctuations in these anomalies. So, back in August of 2023, seeing an increased number of anomalies, April of 24, and just most recently in June of 24. So picking these up through emergency department data, EMS data, and then really stakeholder reports is in the yellow. So really appreciate our trusted partners who are able to, give us this information, keep our lines of communication open for us to be able to kind of do work and really develop this more comprehensive picture of overdoses in the county, so that people are informed and can appropriately respond with resources to where it's needed.